Good morning all. Can you hear me? الصوت مسموع؟ Okay. Good morning all. Good morning Dr. Hisham. Good morning Dr. Ibrahim and our viewers, audience. It's always a pleasure to be with you all, and I'm thankful for the kind invitation. Today, in the upcoming minutes, we will touch a very interesting and hot area in the relation between the cardiovascular medicine and imaging in general, especially speaking about the relation of global longitudinal strain, and we will come to this later, measured by echocardiography, and how can we employ this symbol and bedside and semi-quantitative technique for evaluation or measurement of what we call late infarction size in patients who have passed through myocardial infarction. And we are asking a very interesting question. Can this symbol technique, the echo, overcome, or in other words, surpass the cardiac MRI? Before going deeply, I'll start by my background. I'll discuss the facts we have, and then the problem, and then what is planned in my lecture. Number one, let's start by the facts. Infarction size is one of the major determinants of short and long-term major adverse cardiovascular events. This means patients with large infarction size are more prone to develop major adverse future cardiovascular events such as heart failure, mortality, and rehospitalization. Specifically speaking about the late infarct size, which is usually measured 3 months after the index event. For example, if the index event is January and you have measured the infarct size in April, this is called the late infarct size. It's otherwise known as final infarct size. And this infarct size, I mean the final infarct size, have been linked to important complications such as life-threatening arrhythmias and hospitalizations for heart failure. Up till this moment, the gold standard all over the world for measurement of late infarct size is the late gadolinium enhanced cardiac MRI. These are the facts, but we have a problem. The problem is that the widespread adoption or application of cardiac MRI is not still a reality. It's difficult. And this is understandable because it's not easily accessible. This is an expensive technique, time-consuming technique, leads long scanning times, in addition to other patient-related factors. I mean those patients with cardiac devices such as pacemakers, for example, and those patients with renal impairment. You know that gadolinium could induce some form of adverse systemic fibrosis in patients with renal impairment. And the focus for this reason has been shifted now to use some readily accessible, reproducible, and less expensive simple bedside techniques that could predict the late infarct size in those patients. These were the facts and the problems, and finally to the plan. Our plan in the cardiology department was to thought, and we thought that it's interesting if we could explore the predictive value of this simple technique. I mean the global longitudinal strain, and I will explain it now, using echocardiography for measurement of late infarct size among a group of patients with first STEMI, and by STEMI I mean ST elevation MI, and this is the largest and let's say the most dangerous type of myocardial infarction. Those patients who were treated emergently by stenting, this is called the primary BCI. The patient comes from the street directly to the cath lab in order to be treated by stenting. This is called primary or direct BCI. we thought that we could use global longitudinal strain, which is semi-quantitative and simple, as I just said, to measure late infarct size and compare it to the more expensive, time-consuming, not easily accessible cardiac MRI. Actually, this was a very important paper that was published in the International Journal of Cardiovascular Imaging, which is the official journal of the North American Society of Cardiovascular Imaging. We have a very good collaboration with our colleagues, including one of our colleagues in the cardiology department. I remember him with all good, Dr. Mohammed Afifi. This is a Q2 journal, and the abstract has been accepted in the European Heart Journal, which is a Q1 journal and has an impact factor exceeding 9. And let's go to the details. First, what is that said global longitudinal strain? Let's have an idea. As all you know, that Doppler has an Achilles heel, and the Achilles heel of the Doppler is the angle dependency. The ultrasound beam should be nearly parallel to the direction of the blood flow in order to accurately obtain the correct velocity of the blood flow. Let's say an example. If this is a blood flow and its actual velocity is 5 meters per second, and the Doppler beam is parallel to the blood flow, the angle here is 0, and the cosine of the angle is 1, so the measured velocity will be the reality, 5 meters per second. Compare this to this. If the ultrasound beam is perpendicular to the blood flow and the angle is 90, the cosine of the angle is 0, and anything if multiplied by 0 will give 0. So in this case, can you imagine the measured velocity will be 0 meters per second, and this is totally wrong. This is not the reality. So we can say that angle dependency is the major pitfall of Doppler. On the other hand, strain is an angle-independent technique. You can understand strain as a dimensionless index, measuring the deformation of an object relative to its original size. For example, if we consider this is the left ventricle, and in systole, we know that the left ventricle shrinks. If it shrinks about 20% less than its original size, this is called negative 20%. This is the strain. Again, it's a dimensionless index, measuring the deformation of an object relative to its original shape. If you have understood this slide, you have got in your heart what is a strain. To go deep, let us speak about what we call speckles in echocardiography. Any echocardiographic image shows some points that's, let's say, with high density. These are called speckles. This is a speckle, this is a speckle. So if I can follow these speckles from frame to frame, I can measure how the left ventricle or the right ventricle or any chamber in the heart is deformed during motion of the cardiac cycle. By note, speckle tracking is translated into Arabic التتبع النقطي ده علشان الرسائل اللي ممكن تتعمل. If we would like to understand deeply how could we employ this speckle tracking to measure the strain or to measure the deformation, let's look at this detailed picture. This is a point, and when it moved during systole, it moved to here. So the distance on the x-axis is accompanied by a movement or a distance on a y-axis from the old location to the new location. Imagine how many speckles I can follow by this manner. For example, this is a speckle, and when it moved, it becomes here. And this is a speckle, and when it moved, it becomes here, and so on. Accordingly, we can delineate or determine the endocardial border and then the epicardial border in one or more cardiac views in echocardiography, the apical 3-chamber, the apical 2-chamber, and the apical 4-chamber. And then by using this speckle tracking, we can draw many lines. These lines, as you could understand, should be negative. This is because the size of the left ventricle during systole is decreasing, or in other words, is less than its size during diastole. So, the value of the global longitudinal strain is a negative value, and this is a very important piece of information. The normal is equal to or less than minus 18.5. This means that minus 19 is better. Minus 20 is better than minus 19. Minus 21 is better than minus 20, and so on. And vice versa. Minus 17 is worse than minus 18. Minus 15, for example, is worse than minus 16. Minus 10 is worse than minus 11. The less negative, the worse. Please keep this in mind. Back to the methodology in the current study. In the current study, we included in the final analysis 100 patients, all with ST elevation myocardial infarction, treated by emergent stenting. This is called primary PCI in Penn University Hospital. All patients underwent baseline global longitudinal strain using the methodology just described in the previous 2 minutes. And then, after 3 months, all patients underwent gadolinium-enhanced cardiac MRI in order to accurately measure the late infarct size or the final infarct size. And we thought in this study to see if this global longitudinal strain measured within few minutes at baseline could be used to accurately predict the late infarct size measured by the gold standard at 3 months or not. Based on the amount of late gadolinium in the cardiac MRI, patients were divided into 2 groups. The first group was the group with large infarct size, and this was delineated as group 1. Those patients with large infarct size are those patients in which gadolinium covered more than or equal to 20% of the left ventricular myocardium. On the other hand, the next group was group 2, which was the group with a small infarct size, in which the gadolinium covered less than 20% of the left ventricular myocardium. So, group 1 is the group with large size, the worse group. Group 2 is the group with a smaller infarct size, or the better group. And this is a real case example. The figure number A represents the global longitudinal strain as measured by echo. The mean of all these segments, actually these are 17 segments representing the anterior septal, the anterior, the anterolateral, infrolateral, the inferior, and the infroseptal. This is the base, and this is the apex. Imagine here that I am cutting the heart in a short axis manner. The global longitudinal strain here was minus 15.5. And if you calculate the global longitudinal strain of the anterior segments, which am I highlighting now, it was found to be minus 15.4. The baseline ejection fraction measured by the Simpson method was 55%. These were the details of the baseline GLS of this patient. Actually, this patient was the patient number 20. The image number B represents a stack of short axis cardiac MRI of the left ventricle in late gadolinium enhanced. The enhanced area here represents the scar, and the scar here is covering about 15% of the left ventricular myocardium. So this patient belongs to the group 2, which is the group with a smaller infarct size, again in which the gadolinium covered less than 15%, 20% of the left ventricular myocardium. This is a real case example, a global longitudinal strain done at the baseline, and then a cardiac MRI, gadolinium enhanced cardiac MRI done at 3 months. Let's look to the details, the results. If we compared the baseline characteristics of both study groups, there were no significant differences between those patients with large infarct size, which were 57 patients, and those patients with a smaller infarct size, which were 43 patients, except in one parameter, the age. As you see, the age of the patients with large infarct size was significantly higher than the age of the patients with a smaller infarct size. And this is understandable. The older the age, the more chance to have a large infarct size after you pass through a myocardial infarction. I don't like to go through the details of the myocardial infarction and the procedure of stenting itself, which is called primary PCI, but I would like to draw your attention to a very important 3 facts, and I am highlighting them here. If you look to the maximum troponin elevation, which is a direct reflection of the amount of myocardial injury, you will find that the group 1, which is the group with large infarct size, the maximum troponin elevation in them was significantly higher than group 2, and this is understandable also. If you have a large amount of myocardium injured, it's expected to have a large infarct size when measured by the gold standard. If you look to the time interval passing between the occurrence of chest pain and stenting, which is called the total ischemic time, you will find that the total ischemic time in large infarct size is significantly higher than the total ischemic time in patients with a smaller infarct size. And this could also be logic. If the time passing between chest pain and the curative therapy is longer, it's expected that the amount of infarcted myocardium will be larger. And if we compared the echocardiographic parameters between group 1, which is the group of large infarct size, and group 2, which is the group again with a smaller infarct size, you will find that all echocardiographic parameters are favoring the group with the smaller infarct size. If you would like to have some details, let's go deep. If we look to the end diastolic volume, it has been found to be larger in the group with large infarct size compared to the group with a smaller infarct size. This means that patients with larger infarct size, their ventricular dimensions were larger, and this is also logic and understandable. The ejection fraction also in the group with large infarct size was lower, significantly lower than patients with large infarct size. And here comes a very important point. The baseline GLS in the group with large infarct size was minus 12.3, and in the group with smaller infarct size was minus 15.8. Do you remember if when I said few minutes ago that the GLS, the less negative, the worse? Here, the group 1, which is the group with larger infarct size, showed, let us say, worse GLS compared to the group with a smaller infarct size. In other words, the GLS here was less negative than the GLS here. Please remember, minus 12 is worse than minus 15. The more negative, the better. The less negative, the worse. And this figure is a very important figure. We have asked ourselves a question, and I'm sure you are asking it now. To how degree both parameters, I mean the GLS and the cardiac MRI, are correlated? And actually, there was a very good significant correlation between both parameters. And let's look to the details. Please concentrate on the figure number A. The y-axis represents the infarct size at 3 months as measured by the gold standard, which is the cardiac MRI, and the x-axis represents the baseline GLS as measured by echocardiography. If you look, the more negative the GLS, which is the more better, the more or the less amount of gadolinium enhancing the left ventricle. This means when you go better with the GLS, the amount of the gadolinium enhanced cardiac MRI is less, and vice versa. When you go higher with the GLS, it means the GLS becomes worse, the amount of the infarct size increases. And this was also true if you measured the GLS for the anterior segments, and the anterior segments are the segments supplied by the left anterior descending coronary artery, which is the artery responsible for the anterior myocardial infarction. When you go better with the anterior GLS, the amount of the myocardium enhanced by cardiac MRI is less. And the vice versa, when you go higher with the GLS, it means that the GLS becomes worse and worse. The amount of infarct size by cardiac MRI go higher. So the better the GLS, the better or the lesser the infarct size, the worse the GLS, the larger the infarct size. If you look to the R value here, which is the value representing the Pearson correlation, it was negative 0.8 for the GLS. This means a strong negative correlation, and negative minus 0.86 for the anterior GLS, and this is also a significant, strong negative correlation. This is a very important fact that both techniques are correlated. Importantly, we have to answer our main question. Is baseline GLS predictive for late infarct size? Could it predict the amount of infarct myocardium? And you have, for this reason, to do this curve. And this curve, if you look to any paper, is called the ROC curve. In the ROC curve, we measure what we call the area under the curve. And the area under the curve, when it is approaching 1, this means that this technique is predictive for the outcome. For example, the area under the curve for the GLS for prediction of the late infarct size was 0.85, which is a very good. And the area under the curve for the anterior GLS was 0.9, and this is excellent. Not only from the ROC curve you can predict to how degree the technique is predictive for the outcome, you can also extract the best cut-off points in which the GLS can accurately predict the late infarct size with the highest specificity and sensitivity available. And it was found to be minus 13. In other words, those patients in whom GLS was better than minus 13, for example, minus 15 or minus 16, had higher propensity to develop smaller infarct size. And those patients in which the GLS was worse than minus 13, let's say minus 11 or minus 10, had higher propensity to develop larger infarct size. And please remember this figure. Using a statistical technique called linear regression, we have found a very important fact. For each 1 point reduction in the GLS, I mean in the baseline GLS, there was a 1.6 corresponding increase in the late gadolinium enhancement. In other words, if we have 2 points reduction in the baseline GLS, multiply this by 2, you have more than 3% increase in the amount of the myocardium showing late gadolinium at 3 months. Not only, again, that they are correlated, the first could predict the second with specific equation. Remember this equation, please. For 1 point reduction in the baseline GLS, there is a corresponding 1.6 increase in the late gadolinium enhancement at 3 months. And in order to be more and more expressive of the results, let's see what are the best predictors for large infarct size. Those patients with gadolinium covering more than 20% of the left ventricle. We did a statistical technique called multivariate logistic regression, and we found that these are the predictors. Let's go to the details. For example, the maximum troponin T level predicts the large infarct size by odds ratio of 1.9. What does this mean? This means that for every 1 point increase in the maximum troponin level, there is 90% chance of having a larger infarct size. If you look to the baseline GLS as a predictive factor for large infarct size, you will have the odds ratio of 1.73. What does this mean? This means that for 1 point worsening in the baseline GLS, there is 73 more chance to have a large infarct size. The anterior GLS, I mean the GLS measured exclusively for the anterior segments, was also among the predictive values or predictive factors for large infarct size. And the odds ratio here, imagine, was 8.85. What does this mean? This means that for every 1 point worsening in the anterior GLS, there is corresponding more than 8-fold the chance to have a higher or larger infarct size. So we can say that the predictors for large infarct size are maximum troponin elevation, baseline GLS, baseline anterior GLS, and of course the baseline ejection fraction. If we would like to conclude what we have said within the previous 20 minutes, we can say that semi-automated calculation of early baseline GLS significantly predicts and correlates well with late infarct size at 3 months measured by the gold standard, which is the cardiac MRI. And this represents a very promising, simpler, and readily accessible tool. It could be done within 5 minutes whenever cardiac MRI is not available. Thank you for your listening. I'm grateful that you listened.